Good morning. I think everyone can see me, hear me, and see the presentation. Coming to you from the Dengue branch, the CDC Dengue branch in San Juan, Puerto Rico. This morning I'd like to talk to you about the clinical aspects of dengue management and some of the challenges and opportunities that we have. So a quick review, we've covered a lot of this already. What is it that we can do to reduce dengue morbidity and mortality? Under primary prevention, of course, is the things that we can do to prevent people from actually getting dengue in the first place. And those are things like vaccine, which are under development, vector control, which we just heard about, and education of the public, telling people to reduce mosquito breeding areas and to use screens and to use repellent. But failing that, we have secondary prevention. So what happens when, what can we do to reduce the mortality rate of people who get dengue? And so the first thing on this list is clinical management and clinician education. And I think this is one of the areas where we've already had success, and that is if a patient receives the recommended treatment for dengue, then they're much less likely to die. There's also research ongoing on antivirals, which do not currently exist for dengue. There's active research on improving diagnostics. And there's also, again, a component for the public, which is to educate the public about warning signs and when they should seek care, because the earlier they seek care, or if they seek care if they have dengue warning signs, that reduces the chances that they would die from severe dengue. To quickly review the natural history of a dengue virus infection, let's say you're infected. In many endemic areas, about 5% of the population becomes infected with dengue virus every year. The vast majority of them, of course, are asymptomatic, but about 25% will go on to have symptoms. And almost all of them will just have regular dengue. Only about 1 to 5% will have severe dengue. And out of that, a very small percentage die. With proper treatment, the percentage who die should be less than 1%. To review the timeline, we have the incubation period, which is usually several days to a week. Then we have the febrile phase, which is about 2 to 7 days, and that's when the patient is viremic. That's followed by the critical phase. Once the patient no longer has fever, either the patient will go into sort of severe dengue at that point, or they'll get better. But that 1 to 2 day period is the critical phase, because that's when you need to watch them for worsening their symptoms. And then after that, of course, is the convalescent phase. What can occur in each of these phases? So during the febrile phase, a patient may become dehydrated, they may have hyponatremia, they may have febrile seizures. During the critical phase is when they can get shock, and organ damage, hemorrhage, or encephalopathy. And during the convalescent phase, they may get fluid overload, as well as pulmonary edema, and that's due to receiving too many IV fluids, basically. During the convalescent phase, the fluid goes back into the veins and the blood vessels. And so if the IV fluids aren't stopped, you can fluid overload a patient at that time. So the causes of death, the main causes of death in dengue are, 1, lack of or a late diagnosis of dengue. And so proper treatment is not initiated in a timely manner. Number 2, unrecognized shock or prolonged shock. A lot of times clinicians may fail to recognize that the patient is actually going into shock and do not correct that as soon as possible. Unrecognized occult hemorrhage. Sometimes the bleeding will not be obvious, it will be internal, and so it's not recognized and the patient can bleed internally. Fluid overload, as I've mentioned before, and nosocomial sepsis. So sometimes if the patient is hospitalized too long, they'll get a nosocomial infection in the hospital. To briefly review the previous classification, we've touched on this in previous presentations. Used to be that we divided it into dengue fever dengue hemorrhagic fever, and then dengue shock syndrome as a component of dengue hemorrhagic fever. But more recently, we've moved to dengue with or without warning signs and severe dengue, which is, that severe dengue replaces the dengue hemorrhagic fever, dengue shock syndrome paradigm. And so one of the reasons for moving to this system is now we have this very clear category of warning signs, and that's the indication to, the physician that this patient, if they have warning signs, is at risk for developing severe dengue, and we want to make sure we stay on top of that patient and monitor that patient very closely. Here in Puerto Rico, we've done a few studies to find out more about how patients are treated. And so there was a fatal case review in 2007. We had a large dengue outbreak in 2007 in Puerto Rico with several deaths. And so a review of these deaths showed that there were some poor clinical practices being done, such as using corticosteroids and using hypotonic saline, especially while the patient was in shock. We don't want to use steroids in dengue patients, and we want to make sure we use isotonic saline, such as Ringer's lactate or normal saline, especially while the patient is in shock. We also performed a survey of physicians. Several hundred physicians responded to this survey in Puerto Rico back in 2007, 2008. And this survey identified further clinical practices that were consistent with the fatal case review. And it found gaps in knowledge regarding the diagnosis and management of dengue, as well as gaps in the deficiencies in the recognition of early signs of shock. And so just to summarize, the issues that were discovered was that there were problems with intravenous fluid management, when to give them, what kind to give, how much to give, and also when to change the colloid. That was another issue, was that many clinicians were not aware that once you have given a certain amount of IV fluid, saline, that if it's still, the patient is still in shock, you need to switch to colloids such as albumin. There were also issues with using blood products. Clinicians were not aware of the need to give blood transfusions, especially when the patient is bleeding, actively bleeding. There were problems with monitoring, things like needing to monitor vital signs frequently rather than once per shift, like once every 8 hours or something like that. Instead, you should be monitoring dengue patients in the hospital once every 2 or 4 hours at the very minimum. And intake and output, fluid intake and output was not being measured in some of these dengue patients, and that's important to know how much fluid you should be giving them. We saw practices that were not recommended, so we saw giving the use of steroids, the use of hypotonic, such as half-normal saline, and we also saw that some patients were receiving prophylactic platelet transfusions. And what I mean by that is they were giving platelet transfusions only because the platelet count was low and for no other indication. And so they were prophylactically giving platelets when that's actually not indicated. Other management issues, as I alluded to earlier, prolonged shock. The clinicians weren't recognizing that the patient was in shock, and so that would lead to patients having metabolic acidosis, encephalopathy, and end-organ failure. Prolonged shock is also the reason for a risk factor for GI bleeding. And so if you don't recognize the shock and the patient continues being in shock, that patient is at increased risk of having GI bleeding. Too much or incorrect fluid, such as the half-normal saline, and that would lead to worsening effusions, dyspnea, pulmonary edema, and acute respiratory distress syndrome. Secondary infections in infants and the elderly, and then finally abdominal compartment syndrome, especially in infants and young children who were given the hypotonic saline. In response to these issues, we developed here at CDC Dengue Branch a dengue clinical management course. And so the objective of this course was to increase physician knowledge about dengue clinical management. And the way we did it is because we wanted to train basically the entire physician workforce of Puerto Rico, which is quite extensive and ended up being more than 8,000 physicians. And so what we did was we trained about 30 or 40 master trainers who are doctors in Puerto Rico. They were mostly infectious disease physicians, pediatricians, hospitalists, people who work in emergency rooms and ICUs. So we trained them to give the course, and so they gave the course over about 50 sessions to about 8,000 physicians here in Puerto Rico. In 2010, the Puerto Rico Secretary of Health issued an order requiring all physicians in Puerto Rico to take this course, which is a 4-hour course. And so this was a massive thing that covered the entire island. Later on, a couple of years ago, I did some research and evaluated this program to see if it was effective. And I reviewed 1,500 inpatient charts to see, if there was a change between before the implementation of this course versus after. And I did find that there was an improvement in many aspects of dengue clinical management after this course. So the good news is this course is now online, and so we no longer have to give it in person. That was very labor intensive and time consuming. So we developed this online course, which is 5 modules, including case studies. And so that's very important for physicians. They really like case studies to learn about clinical management. And this also contains videos to illustrate concepts. And it's available basically on demand. So whenever a doctor wants to view it, he can. And especially after seeing a dengue patient, this is a nice reinforcement. And so everyone can go to our website to look at the course. It's www.cdc.gov/dengue/training, and it's 4 hours of free CME if anyone has needs credits for that. But that's offered for clinicians, and that's what the course homepage looks like. We also developed a pocket guide. Physicians really enjoyed having this pocket guide that they could put, like, for example, in their white coats for a quick reference. And I believe I sent several copies over to Trinidad, which you hopefully have in your hands to take a look at. There are 2 forms of this pocket guide. One is the one that you have in your hands in Trinidad, which is the one you can just put in your white coat pocket. Another one is a version that is on our website as well, which can be just printed as just an 8-page pocket guide. And in this guide, many of the issues that I've discussed are a nice summary of what the basics of clinical management of dengue are. We're also developing an electronic mobile app that can be used hopefully on things like iPhones and Androids. That will hopefully be released, in the next year or 2. There are a lot of opportunities for research. There's a lot we don't know about dengue clinical management, and so here's a list of a few of those things. First is admission criteria and timing of admission. So with the 2009 WHO guidelines, they sort of came up with new admission criteria for dengue, and so we need to do more research to figure out if how these admission criteria are working. Are people following them? Are physicians following them? And are they overwhelming our healthcare facilities if you actually follow them correctly? Crystalloids versus colloids. So this is the whole debate about whether or not you should be immediately doing things like albumin or dextran or starches, or if you should do trials of normal saline first, and which are the best colloids to use. There's not much experience over here in the Americas as much as there are in Asia with things like dextran. Here we tend to use more albumin, but there hasn't been the research to show which one is the best colloid to actually use. Utility of platelet transfusions. So what we've been recommending is that platelet transfusions only be given if the patient is having clinically significant bleeding. A lot of doctors still are giving platelets just because their platelet count is less than, say, 30,000 or 20,000, but without any other clinical indication. That's probably not indicated, but there needs to be more research on that, as well as the use of transfusions of fresh fluorescent plasma. Currently, we think that that should only be given if the patient is in DIC, has DIC. A really big area for research, which I think is progressing, is to validate non-invasive hematocrit monitoring methods. Because currently, in order to monitor a patient's hematocrit levels, you have to draw their blood, spin it down, and if depending on the lab, sometimes it takes a while because they're not doing it right on the hospital floor. They actually have to send it to a lab somewhere else, and so that delays information about the patient information that you can use to take care of the patient. But now they're trying to use things that are similar to pulse oximetry monitors to be able to measure what a patient's hematocrit level is that way. So it's non-invasive. You can do it, very frequently, even continuously if you want, and hopefully that will be coming to us soon, because that will be much easier than to, prick a patient for blood every hour or two when you want to know their hematocrit levels. We need to develop a rapid test, ideally, that would predict who will develop severe dengue. It would be very nice, because then you can automatically know, okay, this patient needs to be monitored in the hospital because they're at high risk of developing severe dengue. So we'll see if that can come to fruition. And finally, we should perform clinical evaluations of the warning signs to see how accurate they are in predicting severe dengue. We believe that if you have these warning signs, you're more likely to develop severe dengue, but we need sort of more studies to show that that's actually true, or how good that is at prediction. So to bring it back to where we were in the beginning, there's the primary prevention of dengue, and then the secondary prevention of dengue, which I've talked to you about, relating to clinical management and education of physicians, nurses, etc., which will help in reducing the morbidity and mortality due to dengue. Other areas of research, of course, include the diagnostics and the antivirals and things like that. But hopefully this will gives you a nice overview of what is current in the field and where we need to go. And I do encourage you all to visit the course website, the CDC Dengue course, to see what we've been teaching the physicians, and as well as the pocket guide, which I think is a useful tool. Thank you very much.